right, welcome to our live surgery now. This is going to be our introduction to our patient. We're going to be doing sinus surgery and posterior implants. So let's go ahead and take a look at some of these slides. Here we have a 30-year-old female, good health patient, happens to be missing posterior teeth, one anterior tooth. We're excited to plan implants for her in the upper left in this video series. Let me go ahead and show you an occlusal view. You can see good broad bone. Tissue is thick and nicely keratinized over the crest of the ridge. That will be our surgical site there, just distal of number 12. So we're going to be doing a number 13 into native bone, and then a number 14 into the sinus with a small sinus lift to create a little bit more vertical space. Here's one more view of the soft tissue. You see a little bit of trauma from her removable partial denture that she wears. She's excited to get rid of this with this surgery. This is going to be a really exciting time for her. Let's jump into the CT and take a look at the anatomical structure of the bone. So here's number 13. As you can see, a kind of a weird radiolucency in the bone. So decent bone quality other than that low density area. I'm not concerned with it. I've thoroughly examined the area. I don't see any foreign body or any concern there. I think that's going to be just fine, but that is where our number 13 implant is going to go, is right there. Number 14 implant, as you see, we have a little bit of a low sinus. I can get just barely a 7 in there without any grafting. My hope is to do at least an 8.5, maybe a 10 millimeter length implant. And so we're going to lift the sinus anywhere from 3 to 5-6 millimeters is my guess today. But you can see good bone quality for posterior maxilla. Overall, I think this is going to be a great case. I don't see any red flags. The sinus has been evaluated. It looks very healthy. I see no inflammation in the sinus. I think this is going to be a fantastic candidate for a crestal approach with our guided DDA system. Let me show you a few screenshots from the planning files. So here's number 13 implant in the planning file. You can see we're very close to the sinus. Personally, that's where I like to put my implants. I like to at least gauge that inferior border of the maxillary sinus. That cortical bone is strong. In an area of the mouth that typically is pretty weak bone, I would like the floor of the sinus to be very close to the apical end of my implant, and you see we planned it there perfectly in the virtual world. And so I like that. They've indicated on my plan there, hey, we are close to the sinus wall. I feel like saying, yes, thank you, that's exactly where I want it. And so I love that for number 13. As you see, we have planned a 4x10, and the offset is 9 millimeters. Number 14 is a 5x7 right now, and like I said, I think we're going to do at least an 8.5, maybe even a 10. We'll see how it goes in surgery. But you can see that implant is planned beautifully relative to the prosthetic tooth. You see it's just barely jumping up into the sinus, and that's when we're going to use the sinus kit with the master kit. We're going to jump up into the sinus, graft it with some synthetic bone, and then create vertical space for a longer implant. So that's our surgical plan for today. Those screenshots came directly from my portal on the DDA website, and that's how we evaluated and made our surgical plan. I think it's a good plan. I'm excited to see how surgery goes. One thing I always like to highlight with the DDA workflow is this case in a box I did. You see my surgical guide there. It's planned to do other implants later at different stages as she can manage that. But I have my surgical guide. I have my implants. I have some abutments. We're ready to rock and roll. Let's go ahead and get started with surgery. Okay, here's our patient for number 13 and 14. Again, 13 is a native bone, decent bone quality, a little bit of a low density area, and then number 14 is only about 6 millimeters into the sinus. So we're going to go ahead and do surgery right here. I went ahead and put just about a carp in the buccal and maybe a quarter a carp at the palate. I used Septicaine 4%, 1 to 200,000 epinephrine, and just waiting for it to soak in a little bit. The first thing we're going to want to do on any case is to make sure we try our guide in and it fits properly. This is always an exciting thing because if this guide doesn't fit just beautifully, we can't start with our surgery yet. So I'm going to go ahead and roughly seat it, and then once I feel like we're lined up, I'm going to put some good pressure, and this one literally clicked into place, which I will take. And then my eye likes to look right around here. Make sure it's sitting nicely. Buccal contour. You're seeing same thing right here. Same right over there. And if I get a mirror, you can check the distal areas as well. All these little windows are there to help you visualize the guide seated everywhere. Real big for me if you can. Beautiful. That right there is beautiful. That could belong in a textbook. Look at that. Beautiful fitting guide. No rocking or anything. Where we're going to focus right now is in this site. The fact that I see a gold sleeve means that this is a narrow implant site. The other ones are blue, blue, and so here at gold is a narrow implant site. So I love that. That fits beautiful. Give you a little more medicine, okay? Okay, the guide is seated properly. The patient is numb. I now need to refer to my drilling protocols for number 13 and 14. I'm going to go ahead and do 13 first, get it all the way to completion, and then I'm going to do number 14, okay? So number 13 drilling protocol, we'll start with the tissue punch and a bone flattening drill.
Just falls right there.
So here's our tissue punch. Again, it has a radial or radius blade here. As we tissue punch circumferentially, this will also scrape the top of the bone, getting that bone or getting the soft tissue off the bone. I love this tissue punch. Because the tissue punch and the bone flattening drill are the same for 13 and 14, I will go ahead and use those both at the same time. So I'm going to go 13, 14 here. Go ahead and turn way to your right. Way over and real big. Is that as big as you opened?
Uh-huh.
No. Going to push hard, roll, and out. I didn't get it just yet. We're going to go one more time. Sometimes the drill extension might be needed. If you're a right-hander going across the arch, sometimes that drill extension is needed. I'm going to go ahead and try this one. Real big for me. I'm going to push down. I like a little wiggle. Push hard. That typically does it. There's the tissue. I'm going to see if the assistant can suck that out with the suction. Beautiful. We're going to go and do the back one now. Push hard, little wiggle, push hard. Got some of it, not all of it. And there it is again. So both are tissue punched. No reason to take the guide off. Now I'm going to go ahead and use the bone flattening drill. Just to that first black line. That's plenty. A little bit of bone there. We're going to irrigate. Turn my way again. And again, just that first black line, pretty soft bone there. That looks good. A little bit of bone there. We could harvest that if we wanted. She's going to irrigate. Now, according to our drilling protocol, we're going to put our tube in, and with the tube in place, we're going to go ahead and start our pilot drilling. And again, I'm just going to do number 13 first. Okay, so here's our drill tube. This is going to go into place into the guide sleeve. Sits flush, beautiful. This is our 2x5 according to the drilling protocol. All the way to depth and out, and then we're going to irrigate in between. Next drill is a 2x10. Okay. So now we have a 2 by 10, real big for me. All the way to depth. Beautiful. And out. I'm going to go ahead and take this sleeve out. Now, according to the drilling protocol, it's a 2/7 by 5. So 2/7 by 5. All the way down and out. 2/7 by 8/5. And a 2/7 by 10. Now it's a profile drill, 3/8 profile, and then it's time for the implant. So this is our 3/8 profile. As a review, the bottom of the black line is what my recipe is asking for. That's the drilling protocol. So I'm going to drill this right to the bottom of the black line. Right there. This normally has a lot of bone harvesting. Good bone there. I'm saving a little bit of that bone, and I'm going to mix it in with our bone graft for the sinus. So now it's time to put our implant in. Changing my motor speed. Okay, this is a 4/0 by 10, and I drilled to the D3 protocol. I am not using the abutment profile drill because no abutment's going to go in today. That's it right there, right to that depth mark to get the implant all the way to the proper depth. Okay, real big for me. My motor is at 30 RPMs, 35 torque. Just about there. Starting to bind up a little bit. I don't mind that. We're going to use a hand torque and do the rest. Not getting much tighter, so I feel perfectly fine advancing this. That looks beautiful. Right there, I lined it up even though it's not needed. I'm now going to use a rongier and I'm going to remove that. Real big. Little wiggle. There we go. Let's go ahead and take an x-ray. I'm going to take the guide off and we'll take an x-ray of this site. Real big for me. We're almost done. Okay, that looks good. Okay, now number 14. All right, that implant looks great. I'm going to let it just sit there, and let's go ahead and do number 14. If you look at number 14's drilling protocol, it looks quite a bit different than the other one, and that's because this is a sinus drilling protocol. You're going to notice some yellow stoppers and some blue stoppers being used on top of the drills. You're going to be using your sinus kit. That's where you find those stoppers. So you're going to be using your master kit and your sinus kit, both of those in conjunction with each other. Okay, so now it's time. I've already tissue punched and I already did a bone flattening drill, as you probably remember. So I'm going to go ahead and put our surgical guide tube in, and I have a 2x7 drill with a gold 4 stopper. And if you're wondering how I knew to use the 4 stopper, you would have to refer to the drilling protocol. The drilling protocol tells you that. This is part of approach the sinus wall phase, which is phase 1 of our drilling protocol. So I'm going to use my drill tube. The drill tube is going to go in. real big. And now with this in place, you can see there's only a little bit that I'm drilling with. I'm going to go ahead and drill here all the way to depth. Good. And we're going to come out. Open big. She's going to irrigate that. And then my drilling protocol next is a 2-7 by 7 with the 4 stopper. So the drill tube comes out. I'm going to grab my 2-7 by 7 with the 4 stopper on the top right-hand side of your kit. There's my stopper. I'm going to line this up. All the way down, hard push, and out. Beautiful. Next is a 3-2 by 7. Here is a 3-2 diameter, 7 length, 4 stopper. All the way down and up. Now it's time to create the opening into the sinus. The sinus protocol asks for a 17 drill. So the 17 sinus drill, this is found in your sinus kit with the 3 stopper. So the 3 stopper, as a reminder, the sinus drill goes all the way down to 10 RPMs. So very slow drilling. You're going to see this is quite slow. Hard push and out.
Be the same every time. These never change.
Next step is the sinus pusher with 18 millimeter length, again with the 3 stopper. So this is essentially going 1 millimeter more. This is the drill that is going to be pushing just barely into the sinus. Real big. Only a millimeter here, really firm pressure. Beautiful. I always like to see a little bone at the apex. I'm seeing just a little there. Not there, but right there. I like that. She's going to push her water not too deep because the sinus is technically open now. Now this is the fun part of the sinus procedure. I'm going to take the guide off and we're going to use the hydrostatic pressure to lift the membrane off of the bony floor of the sinus. So this guide is coming off. Here we have our hydrostatic pressure tool. This little handle helps me actually hold the nozzle in place. And then my other hand has a syringe. There's sterile saline inside here. And I have about 2 cc's loaded up. I'm only going to push up about half a cc. They say 0.6 on the protocol. So how this works, I'm going to take this, I'm going to hold this right there, seating that properly, making sure no water spills out. My assistant, her job is to keep her eyes there and make sure nothing spills out because my eyes are going to be focused right here on the syringe. And I'm going to push about 1/10 of a cc at a time. So there's about 1/10, then I let go. See the back pressure? 1/10 more, and I let go. A little bit of back pressure. 1/10 more, back pressure. 1/10 more, and some back pressure. So I'm almost at a half cc right now. Right now we've done a total of 1/2 cc. I'm going to let it go. I'm going to lift just a little bit more. A drilling protocol says 0.6, so I'm going to do 0.6. Sometimes I do a little more, but I'm going to be a good boy today and follow the recipe. So there's 0.6, let go. Now my eyes are going to come here, and when this comes off, you might see some fluid come out. I don't right now. Let's get a mirror in there, and let's take a look. So you see our first implant placed right there. There's our opening into the sinus right there. I'm going to plug the patient's nose in just a second, have her lightly breathe through her nose, and then we're going to evaluate what's going on there. So I'm going to plug the patient's nose with the 4x4. A little air there. Go ahead and try to breathe through your nose, out. One more time. I'm not seeing any movement or anything like that. That's a good sign. I'm going to go ahead and use the next drill in our protocol and evaluate what that looks like. I'd like for you to see that water movement a little bit more. So I'm going to try to do something clever here. I'm going to get the guide back in place. Beautiful. I'm going to use this next drill, and then I'm going to do the sinus hydrostatic lift one more time, just because I want you to see that. So I'm going to go up to the 19 drill, which is the next drill in the protocol, with the 3 stopper. And with the 3 stopper, this is going to push an extra millimeter down into the sinus. Very good. Were you feeling that a little? Uh-huh. Okay, let's take some anesthetic. Let's take the guide off just because it's going to come off anyways. Try to lift straight up. I don't want it to hurt that abutment. Are you feeling any of that right there? Okay, good. I think we've got you there. So I've just drilled a little bit more. I want to just try this one more time because I'd like you to see a more meaningful visual of what we're trying to accomplish here. I think we've accomplished it, but I want you to see it a little better. So again, I create a good seal here. I come back here, and I'm going to push about half a cc worth, a little bit. That's it right there. That's another 0.6. I'm going to go ahead and take that off, and now you're seeing the water run out a little better. So watch this. Plug the patient's nose, blow through your nose. See the water run out. One more time. Okay, a little suction for her. All right, let's try that one more time. Blow through your nose. Good job. So you got to see it run out a little bit more. By creating more patency, you're just able to see the water, I think, flow through a little bit more. No air bubbles. That is called a Valsalva maneuver or a Valsalva test. I'm confident now that we can put bone into the sinus and start putting our implant in without any type of perforation there, because I did not see any air bubbles at all. So my bone of choice here, this is a beta tricalcium phosphate. It is mixed with the patient's plasma for a sticky bone application. I have 1/2 cc here. I'd like to use at least 60-70% of it. I think that's going to be just plenty. I'm going to go ahead and I'm going to use my bone packer here. My H value is 9, and because the H value is 9, then I'm going to go ahead and I'm going to use the 9 stopper on my bone packer. Okay? The H value is written on your surgical protocol at the very top. So when you find out what the bone plus gum height is, that's called your H value. Based on your H value, it determines what your bone condenser stopper height is. And again, that table is found on your protocol. Here's my 9 stopper. 9 stopper slides on. And then here's how I like to do this. I come here, my assistant brings the bone right to there. I then take it and I pack it in. I like to get a little bit in the osteotomy before I push it all the way through. There it goes. Beautiful. Let's take some more. I'm going to pack half of the bone that I just showed you on that dish. And then I'm going to take a PA, okay? And that PA is going to tell me exactly how well my bone pack is. starting to clog up a little, so I made sure I pushed it all the way to depth. We got that all the way to depth. If it starts to clog up, you need to get one push all the way to depth. It's just clogging up in the osteotomy. So probably one more scoop. And then we're going to take a PA. And what I'm looking for is a nice, dense, dome shape appearance of my graft material. This material is very radio opaque, one of the main reasons I use it. And it's going to show up beautiful on an X-ray. Beautiful. So I see that nice dome shape. I see the bone is densely put together, and that dense structure of the bone is one more indication that we have not perfed the membrane and it's not getting loose within the actual sinus. So I'm going to pack in just a little bit more bone, and then we're going to put in our implant. If you noticed in the pre-surgery video, I told you there was a 5x7. We're actually going to place a 5x8-5. And so we're going to make sure we have a 5x8-5 ready to go. And then we'll be good. So a little bit more bone pack.
Is there ever a reason why you wouldn't use all of the bone, like the whole half cc?
If you didn't lift it high enough, it would put undue pressure on it. Okay. Or if your assistant drops it.
I bet I can find it.
I don't want it. It's contaminated.
Okay.
Okay. So all the bone pack has been done. I particularly do not like the last visual in the bone disperse picture. I don't like sticking that other instrument and wiggling it around, and so I actually skipped that step. I'm going to go now to my final drill, a 3/8x7. So the guide goes back on, fits like a glove. Again, I got a little extra bone down there I want to get out. My assistant tried donating that. She has to take it now. That's right. So now I'm using my 3/8x7, and there's no stopper on this one. I'm at slow speed. I'm going to keep it at slow speed just for the heck of it. Beautiful. We got all the way through. And I'm going to ask my assistant to activate my implant. 5x8-5. All right, my implant has been activated. This is a 5x8-5. There's my implant. My motor is at 30 RPMs at 35 Newton centimeters of torque. Real big for me. These posterior ones can be a little tricky. Looks like we're going to get it in just fine though. Going to line it up. Go ahead and go pedal to the metal. Sometimes you'll get extra pressure right here. Beautiful, torqued out right at the final there. I love that. Let me get that out of there and we'll get an x-ray of both these implants together. I'm sorry you're feeling that. Is that some good pressure there? one more. I want to get just a little higher. Okay, there's our x-ray. Looks beautiful. Implants look nice and parallel. You see the bone graft around our implant. What's not to love about that? Looking at keratinized tissue profile, we have good keratinized tissue, so I'm very happy with that. I think this could be a candidate for healing abutments. I want to check just one more thing, see how much bone we have around the implant. That looks great. I'm going to check torque values one time. If my torque values are 30 or more, I'm going to go ahead and elect to put in a healing abutment. Otherwise, these will be a cover screw. So I'm going to let that drop into the hex. There it goes. I've got good torque on the back one. The front one, good torque there. These will both be healing abutments. I'm going to go ahead and irrigate out inside of these in preparation for the healing abutments. So again, sterile saline. Beautiful. And then we're going to put our healing abutments in there.
This is for number 14.
Let's take a 4x4. I have one here. Number 14.
Mm-hmm.
Here's a little trick. Sometimes I like putting a little 4x4 cotton back here. Acts as a little bit of a blanket to catch anything that might drop. Just about down. There it goes. Hand tight. Number 14 looks beautiful. Here's number 13. Let's get a mirror and let's show these off. So there they are. There's number 14. There's number 13. Good keratinized tissue, good primary stability, beautiful position. That is a predictable workflow with a sinus lift, mind you. Hope you guys enjoyed. Have a good one. Okay, I'd like to review with you now the post-op CT from the surgery. I'm looking here at implant number 13, and I just want to highlight a few features of the implant placement that I like, that I think really highlight some important principles that we were shooting for in our preoperative planning. So first off, let's start with the apex of the implant. I love the proximity of the implant relative to the floor of the sinus. In this area of the jaw, posterior maxilla, we know that the bone density is typically a little weaker, lots of trabeculated bone. I think it's extremely advantageous to get that apex in very close proximity to the floor of the sinus. If you look at the far right in the sagittal slice, you see even more how nicely intimate the apex of this implant is with the floor of the sinus. So that's intentional. I think a lot of strength is gained from that. That's something I shoot for every time on these posterior maxillary implants. And then with a digital protocol, with the DONAVI protocol, we can consistently, confidently, comfortably do that without any question or concern. So I love that. Notice the buccal plate is thick, it's robust, palatal bone looks thick and robust. Obviously you're seeing a little metal artifact around the implant, which is common on a CT, but it looks like we have really good bone all the way around this implant. Another thing I would highlight, if you look at the trajectory, it's pointing right at the clinical crown of the lower dentition. So we know as far as force management, this appears to be in a really nice ideal position. Obviously that's not the most accurate way of measuring that, but it's always comforting when you see the crown down below and you know the implant's headed right at it. That's a great sign that this is going to be a good, thoughtful restoration with respect to force management. So I really like number 13. Nothing here I'd really change. You see it's a little bit subcrestal. We've got our healing abutment in there. It looks like a really tall healing abutment, but if you recall the surgery, it was just barely above the soft tissue. And so that's the right size healing abutment for the case, in my opinion. You maybe could go a little less, but I think this is the right size. So that's number 13. I'm happy with it. I like what the CT shows us. The CT is always I'm going to tell you the real story. Two-dimensionally, everything always looks good. At least it should. Otherwise, we probably shouldn't be done with surgery. But two-dimensionally, they look really good. Three-dimensionally, you see really what happened. So I like what I'm seeing on number 13 for sure. Let's move over to number 14. Obviously, the first thing we will look at is the sinus graft. I like our graft material. I like that it's compact, it's close together. It's just another reminder that we did not perf the membrane, the fact that the graft is well contained, densely packed together. I like what I'm seeing there. A little bit of style point loss, the fact that the graft doesn't make it all the way over to the medial wall. I don't see a big clinical outcome to it being that way. But I think it's going to work just fine. There is bone all the way around the implant, which is great. We lifted it a good 6-7 millimeters, which is fantastic. I'm happy with how it looks. I think for full style points, I call it, it'd be nice if that graft went all the way over to the medial wall. But I'm really happy what we've done. The implant's probably in about 50 to 60% native bone, and then maybe 40-50% in our graft material. So I like what I see there from a graft standpoint. Same thing, good bone on the buccal, great bone on the palate, and then it's pointed directly at our clinical crown down below, and the healing abutment's in place. So I really like this. Again, what a thoughtful, simple procedure for us as the clinicians, for the patient, to do that type of surgery to create that kind of impact in terms of the bone graft, immediate implants, one stage, and to do it in a timely fashion, I think is awesome for everyone involved. So really, really happy with the clinical result. Again, I couldn't be happier. So it looks really, really good. With that said, I hope you like that surgery. I hope you like these post-operative x-rays that hopefully kind of bring some closure or full circle to the actual clinical case. I think what I'd like to do now is show one more clinical case, and I'll narrate what is going on, but it's another sinus case. I think seeing another one in a different circumstance might just highlight the procedure, the workflow a little bit better. And so let me go ahead and let's play this next video, and we'll narrate what's going on in the next video. I have a video that I recorded I'd love to show you. Bear with me, it's a little bit rough, the video, but it's real, and I think you'll appreciate the realness of the video. What you're seeing here, just to set the stage, this was full mouth extractions and then placing 5 or 6 implants. These things right here are a special fix pin, we call it, that actually go into implants that were placed and help secure an edentulous guide even more. Doesn't have to be edentulous, I guess, but typically I use these on an edentulous case. And so I took out a bunch of teeth. I placed these 2 implants, knowing that I wanted to use them as anchors to help hold the guide in place. I also had horizontal anchor pins. However, there's nothing like a vertical pull down on the soft tissue to hold your guide in place, even better than a horizontal anchor pin, in my opinion. So what you're seeing here is a sinus lift on this number 3 site. And then these again are just little fix pins, we call them, that hold the guide in place. I'm gonna go ahead and narrate this. And there's a little sound to it, but not voiceover. So here's the entire workflow. Here is the tissue punch. Notice it actually pulls the tissue up into the tissue punch, which is really nice. We reviewed that in our hands-on. Here's the bone flattening drill. The bone flattening drill just creates a flat surface on the top of the bone to ensure a really nice table for this drill that we're going to use right here. So here is my sleeve and tube. I'm going to put the tube in place, but now this is a sinus kit or sinus case, remember? So I need to grab the depth stop. So I'm probably looking at my papers there. What's the number of my drill stop? I go up to the kit and I find it and I push that on. And that is the magic, if you will. In the virtual world, we planned exactly how much space was needed, and this stop provides that. So I'm going to push this to the bone. Once on bone, then I run the drill and I push it, come out. My assistant will irrigate between every drill for me. So I'm going to go now. I know I'm done with the drill tube, so I'm going to get that out of there. And now I'm going to switch to my next drill. It's a 2.7 by 7, or by 5 it looks like, and then I grab the yellow depth stop. And how did I know that? The drilling protocol tells me that. So now we're going to drill a little bit more. Simple as that. I edited a few seconds of just my head moving between drills. Otherwise, what you're seeing is complete real time without any big edits. I wanted you to see what this procedure really looks like in terms of real time. I'm not rushing here. This is just normal working speed. So here's the next drill, a little shorter depth stop. So I'm going to get down at least another millimeter here. And now I believe we'll see, I've got one more drill. This is my 3.2 diameter drill. I'm stilling that depth stop again, following the recipe that was given to me. Just widening the osteotomy now to 3.2. With the osteotomy now at 3.2, I'm going to go to the sinus kit and grab my sinus drills. I'm just checking to make sure it's the right length. This is the 17 length with a depth stop. Looks like the pink one's the right one. And this is extremely slow speed. So I'm going to take a second here to change the speed on my motor. That's what the delay is right here. And then with the speed slowed down, we're going to go ahead and run this. And this is almost just pushing the bone, if you will, very gently to gain access to the sinus. So that should be just barely to the sinus, really slow speed. And this next one is the one that's actually going to push through, if you will, and actually gain access to the sinus cavity. And so this is a little bit longer drill or just a shorter depth stop that does the same thing for you. And you'll probably see this kind of push and drop. Not so much of a visual there, but now I know I'm in the sinus per the drilling protocol. Obviously, when you irrigate, I don't want that needle tip pushed very deep into the sinus cavity at this point. Just barely put that in, just a little irrigation. I'm removing these fixed pins to remove the guide so I can do the hydro lift here in just a second. I'm now securing the tubing to my sterile saline syringe. And then I'm going to grab the membrane lifter. I'm going to put the handle on it and then hook up the tubing. And just like you saw in that other video, I'm making sure I've got water primed on it. I've got to prime the pump. And then I'm going to seat this. And I wiggled this around a little bit so you can see you don't want to be too tight with this. Otherwise, it will kind of bend and flex. So just enough where you get a seal, and your assistant can be extremely helpful to make sure you have a good seal, because I believe your eyes should be on the syringe watching what you push. I think that is more important. Just a good steady hold there. And then that scared me right there. It kind of pushed through and I didn't feel any back pressure, but I didn't perf, thank goodness. But did you notice it kind of went a little bit quick there? And so now I'm just slowly pushing, getting to about 0.6 cc's. That's what my drilling protocol recommends. I went a little bit more than that. I like at least 0.8, maybe even 1 cc of total volume. Now check this out. Here's the nose test. No bubbles. I'm seeing the saline, but look at, I see the little hole. There is certainly no perforation. That's a beautiful video there to capture that. That's probably the best part of my video there. I should have stopped it there because now the rest gets a little blurry. I have to do one more drill to create even extra patency so that I can pack my bone. So I'm going to go ahead and run one more drill, and now it's even more patent at the end. And now here's bone packing. This is sticky bone. So I drew some of the patient's blood, spun it for just a couple of minutes, took that serum layer, injected it into my beta tricalcium phosphate. And now, once I get the patient open, I'm going to take that bone and push it on. Notice the depth stop again on my bone packer. There's a purple depth stop there, and I apologize for the blurriness there. This camera's a little new for me, and I didn't do a great job here, so bear with me. It gets a little better here. But I'm going to pack the bone in, and I will say this step right here, although I think it looks kind of easy, it is where most clinicians stumble a little bit and they make this harder than it needs to be. This opening is only 3.2 millimeters, which is a little bit smaller than what a lot of people are probably doing when they're doing crestal lifts. You typically are opening to your final diameter and then lifting. When you have an opening that's only 3.2 millimeters, packing the bone can sometimes get clogged. And notice how I take this to depth every couple of pushes. So I'm pushing a little bit, and then I will take this all the way to depth here in just a second. And that's right there. And that's really important to create true patency through that osteotomy. If you don't do that, you will clog that area up. And by clogging it up, it gets extremely frustrating and it's kind of nerve-wracking. So that's a cc of bone. And I typically place half of it and then take a PA, and I determine if I want to place any more. I was filming this. I went ahead and just placed all of it. You're going to see this takes a little bit of a second, but I placed every bit of 1 cc, and then I put the implant in. I felt like we had a good lift, but you're going to see in a second, I probably put even more bone than we needed in. I should have done a longer implant, might be my regret on this case. But you're going to see I went ahead and I'm packing bone, again, making sure I push to depth, and that depth stop is ensuring I don't push too deep and hurt the membrane. A little bit more bone. Again, I didn't want to edit anything out. I wanted you to see this whole thing in real time, and so this gets a little repetitive here. But we're going to pack more bone. Isn't that sticky bone nice for handling? If you aren't using sticky bone, you probably are like, that looks a lot easier than it should be. And if you just have loose particles, oh my gosh, they go running everywhere. About half of it makes it into the sinus, and the other half gets sucked up through your surgical suction because they fall to the back of the mouth. And so that sticky bone is amazing. I mean, even though, I mean, it has obviously some biologic properties, which is fantastic, but you have to wonder if even the physical properties are even just as impressive, I should say, because handling the bone like this is just so much easier than different methodologies. I've used the different bone trumpets and amalgam carriers and all those different techniques. Nothing's better than just sticky bone on into my periosteal elevator. And I just bring it to my surgical site and then pack in just like you're seeing. Okay, so done bone packing. Now I'm putting the surgical guide back on. I want the guide accuracy for the implant. And so I'm going to load up the dental implant here in just a second. And then we're going to put that dental implant in. So there's our dental implant, loaded it up. This was a 5 by 8.5, I believe. It might have even been a 5.5. No, I think that it's a 5 by 8.5. Sorry again that it's a little blurry there, but you see it going in. There's those little tabs at the top of that fixture driver. Those are depth stops. I want that to be flush with the surgical guide. I'm now maxed out at torque, and I'm just kind of hand cranking it. You always get a little excessive torque reading because the guide and the driver friction. And so I don't mind doing a little hand pumping there to get that down a little further. So I'm going to take one more view at it. There it is in place, and that's the surgery. That's real time. So I think we were about 10 minutes on that case, start to finish, in terms of that single site. Obviously I had the whole mouth or the whole arch to do. But that's awesome. 10 minutes, 12 minutes for that procedure, start to finish, very predictable. And hands down, where I spent most of my time is just packing the bone. The other parts of the process are pretty straightforward. How neat to use technology and take a procedure that can be a little bit more ambiguous, a little bit more maybe challenging, and take it and make it very, very straightforward and simple like that. That's phenomenal. Here are my post-op CTs on this particular case. So this is the case I just showed you. I packed a lot of bone. We should have probably done a 10 millimeter length implant there, maybe even an 11.5.
But again, I knew I was filming this and I kind of just wanted to show you guys, look at that bone graft. I measured it from the top here. That's where my sinus ends. So graft was 8.2 millimeters of lift. And so really nice lift there. To do that with a crustal approach is phenomenal in my opinion. Obviously, some of that will come down just a little bit, but that's a great bone fill right there. Again, that's a clinical case that I appreciate in terms of my contribution to it. The stress, the workflow for me is awesome. The patient to have a service like that is just phenomenal as well. They're always really impressed if they're not sedated, how quick these procedures go. They're expecting some big extended surgery, and that's just not necessarily what implant surgery is today. There can be cases where it's like that, but under the right circumstances, these are pretty straightforward. I chose to put a cover screw on here. I didn't love his soft tissue profile. I felt like I could move some keratinized tissue later. I don't know if you noticed that there wasn't a lot of keratinized tissue. So I'll do an apical repositioned flap later on this case, and that's why it's a two-stage approach in this instance.